Good afternoon, students. Today, the topic we are going to discuss is intertrochanteric fractures of the femur. Like we already discussed, I think a fracture shaft of the femur and neck of femur last time. So this is another important topic as far as the lower limb and femur is concerned. That is IT fracture. What we usually call IT fracture, that is intertrochanteric fractures of the femur. Now, this will briefly cover all the fractures that are related to the trochanters, that is the greater and the lesser trochanters. Among them, the most important is IT, that is intertrochanteric fracture. Whereas isolated fractures can also occur of the greater and the lesser trochanters, but that is kind of less important. But the bigger topic is IT fracture. So, like I said, it covers all these topics. That is intertrochanteric fractures, fractures of the greater trochanter as well as fractures of the lesser trochanter. Specifically, we will come to intertrochanteric fractures first. Usually, intertrochanteric fractures are, as you can imagine, intertrochanteric fracture, the name itself suggests it's a fracture line running between the greater and the lesser trochanters. So it is somewhere below the neck of the femur that we discussed last time. So it has to be below the basic cervical type of neck of femur fracture. So it has to be below that line. So otherwise known as pertrochanteric fractures. That is all the fractures in and around the trochanters. That's why they are known as pertrochanteric fractures. So those occurring in the region extending from the extracapsular basilar neck region, like I said, to the region along the lesser trochanter proximal to the development of the medullary canal. So that area, that's what we call the intertrochanteric or the pertrochanteric fractures. Anything below that, it usually goes to subtrochanteric fractures. That is, of course, a different topic. We'll discuss it some other time. So that is a subtrochanteric fractures. So here we'll be discussing only the pertrochanteric fractures. So intertrochanteric and peritrochanteric are generic terms for pertrochanteric fractures. So all those fractures in and around the greater and the lesser trochanter area. That's what we generally refer to as trochanteric fractures. So most of them are usually extracapsular. As you can imagine, the IT fracture is usually extracapsular. This I mentioned last time when we were discussing the difference between the neck of femur and the extracapsular. The IT fracture, sorry. So neck of femur is usually tends to be intracapsular. I'm sorry that I think it was disconnected. The connection was lost. I think it is back on again. So I was just talking about that. So what we were discussing. So it usually tends to be this tends to be more common in old age, just like a neck of femur fracture. This also tends to be more common in old age. So again, it is related to osteoporosis, just like neck of femur fracture. So that is why it tends to be more common in women compared to men, because they are more prone to development of osteoporosis. So yeah, so it is rising because the increasing number of senior citizens with osteoporosis. So by 2040, they say the incidence is estimated to be doubled as it is compared to what it is now. So that is in brief about the epidemiology. Then of course factors contributing to the development of IT fracture I already mentioned. One is advancing age. Other one is increased number of comorbidities, like maybe if the patient is bedridden or some other systemic diseases like long-standing diabetes, maybe tuberculosis. All those things can in one way or the other contribute to the progression of IT fracture. So increased dependency in activities of daily living, you can say. The history of other osteoporosis related fragility fractures. So anything that is related to osteoporosis, that is advancing age and less bone strength, and all those things can in a way contribute to IT fractures. Briefly, we'll discuss anatomy. It occurs in the region between the greater and the lesser trochanters, like I already mentioned, of the proximal femur, occasionally extending into the subtrochanteric region. But usually we classify them as, it may extend into the subtrochanteric region, but all those fractures which come specifically in the subtrochanteric region, we have a separate topic for that. That is subtrochanteric fractures. That we are not going to discuss here. But IT fracture can sometimes extend into the subtrochanteric region. Since they occur in the cancellous bone with abundant blood supply, that is one, as you know very well, this area corresponds to cancellous bone, what we call the metaphysis, in other words, you can say. So there, as you know very well, the bone is soft, or what we call the cancellous bone. So cancellous bone, as it is, usually has a very high or a very abundant blood supply. So there will not be any problems of non-union and osteonecrosis. If you remember, these two were very common complications with neck of femur fracture. That is very notorious for non-union, and also AVN, that is avascular necrosis. But here, those complications are not found because the bone is cancellous and there is abundant blood supply. So that's one major difference you can remember between neck of femur and IT fractures. Again, deforming muscle forces will usually produce a shortening, external rotation, and varus position at the fracture. So just like a neck of femur fracture, also you get that is external rotation of the limb, but it will be completely externally rotated here because the fracture is extracapsular, whereas in neck of femur it is intracapsular, so it won't be completely externally rotated. That is one major difference between neck of femur fracture and IT fracture. So that point you can keep in mind. That will be the general attitude of the limb. So this is again just a diagrammatic representation of the anatomy, what happens actually when the fracture takes place. You can see there GT, that is the greater trochanter, is displaced laterally and proximally. The hip flexors, extensors and adductors pull distal fragment proximally, and the iliopsoas displaces the lesser trochanter medially and proximally. So that is, if you can just follow those arrows there, you can the abductors will displace GT laterally and proximally, and all the other changes will also take place. So this will give you a brief idea about what will be the or what you can expect the attitude of the limb to be when the patient presents with an IT fracture. Mechanisms of injury, younger individuals, like I already said, if at all it has to take place in younger individuals, if at all that fracture takes place in younger individuals, it is usually related to high energy trauma, whereas it is usually much more common in elderly or older age groups, such as motor vehicle accidents or fall from height, and more common in men less than 40 years of age. That is because of motor vehicle accidents and fall from height and all those things. Low energy falls from a standing height. Approximately 90% of community hip fractures in patients more than 50 years of age, with a high proportion of women. This point I already mentioned earlier. Then of course you need to rule out the other associated injuries and disease states. Like for example, if it is in a low energy fall, you can also all those fractures which are expected in old age, like distal radius fractures, proximal humerus fractures, head injuries. Then high energy hip fractures like in accidents and all that, ipsilateral extremity trauma, head injury and again it seems to have been disconnected. I don't know, we're having some connection problems. I think it's reconnected again. So, coming to clinical evaluation, shortening of the extremity and deformity of rotation resting position compared with the other extremity. This I already mentioned. What is the attitude? Then pain of course will be there with motion and crepitance testing. Obviously all those features of fracture which you have already learned, signs and symptoms like pain, crepitus, all things will be there, and of course they are not to be elicited clinically. They can only be expected, like sometimes they should not be clinically elicited. Theoretically it's fine, but only if the fracture is occult or it is not clear, then you need to elicit these clinical signs and symptoms. Unless there are no obvious physical signs of deformity and radiographic studies are negative for an obvious fracture. Otherwise, you should not actually elicit any of these clinical signs and symptoms, because you will end up making the fracture even worse. So just theoretically you can remember all these signs and symptoms. And there will be pain with axial loading of the hip, a high correlation with occult fracture. That is, if the fracture is not very clear, but you are suspecting a fracture, if you try to axially load, that is, apply pressure along the axial line of the femur, there will be very severe pain in the hip joint. So all these things you can remember as signs and symptoms of IT fracture. Then there is a test known as auscultation Lippmann's test. It's nothing but sensitive for detection of occult fractures of the proximal femur or pelvis, used in both femur as well as pelvis. When you place the bell of the stethoscope on the symphysis pubis, and when you tap on the patella of the both extremities, you will see a variation in the sound conduction. So that variation in sound conduction will tell you if there is a fracture or not. On either side, you can compare with either, or compare both the sides, and then you can see if there is a difference. So this is what is known as auscultation Lippmann's test, where you use the stethoscope to identify whether there is a fracture or not. So decreased tone or pitch will show a sign of the fracture. So that is, you can just remember what is exactly meant by auscultation Lippmann's test. It is used for both IT fracture as well, or fractures of the femur as well as fractures of the pelvis. What about the clinical investigations? All the usual things that we usually do before a surgery, like a complete blood picture, then HIV test, HBs antigen test, HCV, then a renal function test, RBS, blood grouping and cross matching, chest X-ray, ECG, all those things which can be expected to be done anytime before any major surgery have to be done here also. Then for low energy fractures, like in old age specifically, you need to check for other parameters like serum calcium, phosphate, alkaline phosphatase, vitamin D, thyroid stimulating hormone, parathyroid hormone, serum protein, electrophoresis. All these things may need to be done, especially in older patients also, in addition to the other routine tests before a surgery. Then what are the other things you need to look for while doing a workup? A previous history of DVT, deep vein thrombosis or pulmonary embolism, right? Because you need to know if there are any other comorbidities that are present or any kind of conditions. Then anticoagulant medications, if the patient has been on any kind of anticoagulant medications. Then immune deficiency disorders, malabsorption diseases, angina, then any history of cerebrovascular accident like CVAs, then active infections, ongoing infection like pulmonary or genitourinary infection because of risk of sepsis. You need to rule that out. Then of course protein calorie malnutrition, that is PEM. protein energy malnutrition, vitamin D deficiency, because all these things can affect the healing of the fracture, because now they are recognized as serious risk factors for increased mortality and slower recovery. So all these things you need to do in addition to the routine tests. What about the imaging studies? Obviously most important as far as diagnosis is concerned. X-rays, you usually go for a pelvis with both hips, anteroposterior view. Also you can take X-ray of the affected hip, that is AP and cross stable lateral. So you can go for both AP as well as lateral views of the affected hip. AP view of PVH, that is pelvis with both hips, as well as lateral view of the affected hip. Then some specific type of films or a special kind of films used for X-ray known as traction films, where you apply traction to the limb and then take the X-ray. Why is it useful? Because it's helpful in comminuted and high energy fractures. Comminuted and high energy fractures and in determining implant selection. So sometimes some surgeons may require some specific views. They are known as traction views to determine the degree of comminution and as well as the implant to be chosen. All those things can be determined using special views of the X-ray. Then subtrochanteric extension, which I mentioned earlier, if it extends into the subtrochanteric region, you may also need to go for the femur alone. Instead of the pelvis, you may need to go for the femur alone, anteroposterior and lateral views. That is, if you are suspecting the extension of the fracture into the subtrochanteric region, then you need to go for those views also. So these are the usual X-rays that are taken. Then what about CT scan and MRI? Again, just like before in other fractures, some specific cases you need to go for further investigations. Usually MRI is the choice here compared to CT, especially in IT fracture, because it helps in delineating the non-displaced or occult fractures that may not be apparent on plain radiographs. So where you are suspecting a fracture, definitely there is a fracture but it's not very clear on the X-ray, there you need to go for CT scan and MRI, but specifically MRI is preferred here because of the higher sensitivity and specificity for a more rapid decision process. Bone scans or CT, it's reserved for those who have contradictions to MRI, like for example people with existing metal implants or things like that. They cannot go in for MRI, then you can go for a bone scan or a CT scan. So these are all investigations done in specific conditions. Coming to classification, this is a little bit, one or two classifications are important. So it depends on a variety of factors. How you classify IT fracture depends on a variety of parameters. One is posteromedial large separate fragmentation. Second is basicervical patterns, reverse obliquity patterns, and displaced greater trochanteric, that is lateral wall fractures. So again, these are the criteria on which it is classified, but we will just see briefly the important classifications. The first and foremost that we usually refer to, this can be asked as a short note or something like that, is what is known as the Boyd and Griffin classification. Classified into 4 parts. Type 1, you can see the diagrams there, where it is stable and it has got 2 parts. The fracture has just got 2 parts, there is no comminution or anything. So that is known as type 1. In type 2, it is unstable, comminuted with posteromedial comminution. That posteromedial comminution is a deciding factor here. If that is there, then the fracture is unstable. That means it can get displaced at any time. Even though it is undisplaced at the time of fracture, it can go into displacement anytime. So that is known as an unstable fracture. And the criterion that determines that is what is known as posteromedial comminution. So if posteromedial comminution is there, then it is actually an unstable fracture. It can actually go into displacement. Type 3 is unstable reverse obliquity. As you can see here, type 3 in the diagram, there is an oblique fracture line running there. So it is unstable as well as it is reverse oblique. So that is what is known as unstable reverse obliquity. And type 4 is intertrochanteric subtrochanteric with 2 planes of fracture. It's actually extending into the subtrochanteric region also with 2 planes of fracture. Not just a single plane, it is the fracture exists in 2 planes. So that is what is known as, that is one of the most important classifications used here for IT fractures. That is one of the Boyd and Griffin classification. So you can see the diagrams there, it becomes a little bit more clear there. Second one is known as events classification. In events classification, this is more of a surgical point of view. He reported on a post-treatment classification with 5 types described. So this is more of a surgical point of view and post-treatment type of classification. So what he did is he compared non-operative treatment with fixed angle device, we'll just come to that, surgical treatment, and found that 72% of fractures it would be fixed in a stable configuration, whereas 28% were in unstable configuration. So 72% fractures were fixed in a stable configuration, whereas the remaining 28% were fixed in an unstable configuration. And among that 28%, 14% were because of fracture comminution and 14% reduction was never achieved. So 28% were totally unstable. But among that, about half of them, 14% were because of the comminution, and the remaining 14% reduction was never achieved. They could never reduce that fracture. So based on this, the treatment that he observed, he classified the IT fracture into different subtypes. So this is what he classified it into. Type 1 is stable. It is either displaced or undisplaced, but it is anatomically reduced. That is known as type 1. So type 1 is stable. It can be reduced or can be displaced or undisplaced, but it can always be reduced. So that is what is known as type 1. In type 2, again it is unstable. Type 1 is stable, type 2 is unstable. So it implies displaced and fixed in an unreduced position communicated with destruction of the anteromedial cortex or reverse obliquity. So that is known as type 2. Right? So that is type 2 was further classified into different subtypes. So basically it was classified into stable and unstable. If you can remember like that, that will be simple. In type 1 it is stable, it can be displaced or undisplaced, but it is always anatomically reduced. Whereas in type 2, it is straight away unstable and it implies displaced and fixed in an unreduced position or comminution or reverse obliquity. So all of them have been classified under type 2. So just remember type 1 and type 2. Type 1 is stable and type 2 is unstable, which is further classified into further divisions. So that is known as Evans classification, which is not that important compared to Boyd and Griffin. That is more important from a theoretical point of view. This is more from a surgical point of view, it is important. So this is why it was important, because it was able to distinguish stable from unstable fractures and helpful in surgical reduction. So stable fracture patterns, posteromedial, like I already mentioned, the determining criterion here is posteromedial comminution. If that is there, straight away it becomes unstable, but otherwise it remains stable. So, and then of course reverse oblique is also there. It is inherently unstable. Reverse obliquity means straight away it is unstable, right? So that is what is known as Evans classification. So these two classifications are kind of important as far as IT fracture is concerned. Then a third one is also there, that is orthopedic trauma association, that is OTA or AO classification. This is again, it is classified into 31A, A1, A2 and A3. So again, this is from a surgical point of view. First one is extra-articular fracture and the trochanteric area. Type 2 is per-trochanteric symbol fracture. Third one is per-trochanteric multifragmentary type, and type 4 is purely intertrochanteric. So this is again, you can just remember from, you can just make a note of it. This is the third type of classification known as OTA or AO classification of fractures. Right. So these are the classification systems that are commonly used as far as IT fracture is concerned. This is a diagrammatic representation of OTA classification. You can just have a look, read through the theoretical part and then try to correlate with these diagrams. Then there are some unusual fracture patterns like a basic cervical fracture, which is more of a neck of femur fracture, which I already mentioned last time. It is one of the types of neck of femur fracture. So sometimes you might get confused between a basic cervical neck of femur fracture and an IT fracture. And the second one is reverse obliquity fractures. That is again totally unstable type of fractures. These are specific fracture patterns which don't usually fit in with any of the classic classification systems. So that is the unusual fracture patterns. Basic cervical fractures, it is located proximal to or along the intertrochanteric, like I already mentioned, it's more or less a neck of femur fracture. So it's although anatomically femoral neck fractures, they are usually extracapsular and behave like intertrochanteric fractures. At greater risk for osteonecrosis when compared to more distal intertrochanteric fractures, because it's more or less a type of neck of femur fracture. So it lacks the cancellous interdigitation seen with fractures in the intertrochanteric region and are more likely to sustain rotation on the femoral head. So that is a specific type of fracture there. So this shows that this shows the basic cervical type of fracture. This is more or less a neck of femur fracture anatomically, right? So that's the way. Reverse obliquity I already mentioned, an oblique fracture line extending from the medial cortex proximally to the lateral cortex distally. It has a tendency to medial displacement due to the pull of the adductor muscles, and it should be treated as subtrochanteric fracture. So the two different types. One is basic cervical, which is anatomically a neck of femur fracture. Whereas this one is actually anatomically a subtrochanteric fracture. So that is why they are unusual fracture patterns. So they are not purely IT fractures. They are more or less different types of fractures. So these are the specific or special types of fracture patterns. That is a basic cervical and reverse oblique type of IT fractures. So that shows the X-ray there, which you can see there, shows the reverse oblique type of fracture. So technically it's actually a subtrochanteric fracture. It is not a IT fracture, right? So that's the thing. Coming to treatment. Treatment can be non-operative and operative. Unlike neck of femur fractures, here there is some scope for conservative management because, like we already mentioned, this is not prone to non-union or anything. The fracture will unite. Even though it won't be 100% in the anatomical position, it will unite. But it will go for malunion. So here there is a scope for conservative management as far as IT fracture is concerned. Coming to non-operative techniques, as usual, they are always preferred in patients who are unfit for surgery. How do you treat it? It goes for a prolonged bed rest in traction until fracture healing takes place. That is the usual period for around 10 to 12 weeks, followed by a lengthy program of ambulation training. It can be done for elderly persons whose medical condition carries an excessively high risk of mortality for surgery, and non-ambulatory patient who has minimal discomfort following fracture. So in such patients, you can advise non-operative or conservative management. So what are the various options where you can actually consider non-operative management, different types of or techniques of non-operative management. One is bucks traction, which you already mentioned, nothing but skin traction, which you mentioned last time. This second one, Russell skeletal traction, which I already mentioned in shaft of femur fracture. I have already shown you that picture. So that is Russell skeletal traction. Third one is using a Thomas splint, balance traction, Thomas splint, again, which was mentioned in shaft of femur fracture. Then of course, plaster spica immobilization, right? And the last one is known as a derotation boot. This is a special type of boot. It looks like a shoe, which is made using a ruler and a POP. So when the patient is lying on the bed, it prevents the rotation of the foot. So that is what is known as a derotation boot. So these are the various techniques of non-operative management of IT fracture. Complications of non-operative treatment, obviously there will be a variety of complications as far as non-operative treatment is concerned. The first one is decubiti. Decubiti is nothing but pressure sores, or we can say bed sores, or pressure ulcers. Then of course UTI, because the patient is bedridden for a long period of time. Then of course UTI, that is a urinary tract infections. Then joint contractures, pneumonia, thromboembolism, obviously because the patient is bedridden, resulting in a high mortality rate. So, and of course, fracture healing is usually accompanied by varus deformity and shortening, obviously because we'll go for malunion because we are not operating. So these are all the complications that are associated with non-operative treatment. Coming to the definite management, that is always operative treatment as far as IT fracture is concerned. So as soon as the general condition of the patient is under control, internal fixation should always be carried out. That's the preferred method of treatment. Right. Non-operative treatment, what are the factors that determine the strength of the fracture and the implant assembly? What are the criteria which determine what kind of implant or what kind of surgery should be done? That is the bone quality, obviously, fracture pattern, fracture reduction, implant design, implant placement, and all those things will determine what kind of operative management you undertake. Reduction, open reduction, like that is opening the fracture site. That of course is resorted to if there is a failed closed reduction and large spike on proximal fragment with the lesser trochanter intact. Reverse oblique fracture, that is a unique type of fracture line, and if a gap exists medially or posteriorly. In all these situations, you need to go for open reduction. Otherwise, you can go for closed reduction, that is without opening the fracture site. Open reduction techniques, that is anatomical stable reduction, if not severely comminuted, and applying a bone holding forceps across a fracture. These are all surgical techniques. We'll just come to the implants, that is more important there. Then of course, various implants, like I already mentioned, as far as operative management is concerned, two or three techniques can be applied. One is use of implants. We'll just come to that briefly. Second one is osteotomies. That is just like in many other conditions in orthopedics, osteotomies can also be considered in case of IT fracture. So some specific osteotomies, named osteotomies are relevant here. One is known as a medial displacement osteotomy, or what is known as a Diamond-Houston osteotomy. Second one is a valgus osteotomy or a Sarmiento osteotomy. And third one is a lateral displacement osteotomy. So these are, just remember, these are the different types of osteotomies that are used in IT fracture, because a variety of bone conditions in orthopedics have a variety of osteotomies. They're all named after various persons. So here the important ones are these three: Diamond-Houston, Sarmiento, and lateral displacement osteotomies for IT fracture. Then what about the implants? Various implants are used for treatment of IT fracture. Operative methods like plate constructs, cephalomedullary nailing, external fixation, that is obviously if there is an open injury, and of course arthroplasty, that is joint replacement. So these are all the various surgical techniques that can be considered, or operative methods that can be considered as far as IT fracture is concerned. Then there are different types of plates are there. Impacted nail type plate was like a blade plate and fixed angle nail plate devices. Dynamic compression glass. So there are plates are of two types. Either they are fixed angle or they are dynamic. Fixed angle and dynamic. Two types of plates are important. This is, for example, a type of nail that is fixed angle. That is known as a Jewett nail. This is not used nowadays very commonly, but I just need to remember the name. This is a type of fixed angle nail plating. Right? More commonly used for corrective osteotomies nowadays, rather than as a primary treatment of hip fractures. One typical example is Jewett nail. So this is an example of a fixed angle nail. This is the one that is commonly used nowadays. That is known as a sliding hip screw, specifically known as a dynamic hip screw. This is an example of a dynamic plate, not a fixed angle plate. This is a type of a dynamic plate. So specifically it's known as a sliding hip screw, or what is known as a DHS, dynamic hip screw. So that this is the one that is most commonly or gold standard nowadays for treatment of IT fracture. So that just shows an X-ray how it is being fixed, right? Just have a look through it, how exactly surgically this dynamic hip screw is placed in the hip joint. These are the considerations you need to take into all the points or the important criteria you need to take into consideration before operating. There is a tip apex distance. This is all more important from a surgical point of view. So the sum should be less than 25 millimeters to minimize the risk of lax screw cutout. We don't details there. Then the third type is what is known as a plate reconstruction, linear compression class. So we already seen the sliding hip screw. We have seen the fixed angle plate like jewet plate. This is another one known as plate construction linear compression class plates. Examples you can just remember: Gottfried PCCP and Intertan CHS. All these names you can just remember. That's it. Hybrid locking plate. That is a plate construct. That is another one. Hybrid locking plate. A second type of they all belong, all the things that we mentioned until now, they all belong to one group of plates or nails or plates. Here we talk about the second type of implant that is used for IT fracture. That is known as a cephalomedullary device. Cephalomedullary device is the most important or the common one used is a proximal femoral nail. We'll just come to that. So these are sub-classifications. Just remember the second type of implants that are used is known as cephalomedullary devices. Right? Again, just among cephalomedullary devices, these are the important ones like impaction class nail, gamma nail, then recon class nail, and intertan nail, and all those things. This is the most important common one is what is known as a proximal femoral nail. So you can just remember the name like that. The proximal femoral nail is the one that is most commonly used as far as cephalomedullary devices are concerned. Some advantages it has, but the cephalomedullary nail has certain advantages over the previous one, that is fixed angle and compression plates we discussed earlier. It provides more efficient load transfer, it decreases the tensile strain on the implant, it gives a controlled fracture impaction, and it usually gives you shorter operative time and less soft tissue dissection. So these are all the advantages as far as a cephalomedullary nail used in specific conditions. Otherwise, you can always go for internal fixation using DHs or PFN, that is proximal femoral nail, which are the two most common implants used nowadays for IT fracture. Right, so this is the diagram of external fixation. And the fourth method, which I already mentioned, is already arthroplasty, that is joint replacement. Right, if the patient is unsuitable for internal fixation, then you can go for arthroplasty. Like for example, certain conditions like pathological fractures, like in maybe tumors or osteomyelitis, right? And then there is severe osteoporotic disease, renal dialysis patients, pre-existing arthritis, like maybe rheumatoid arthritis or something under consideration for hip replacement before the fracture occurred. So already the patient was supposed to go for hip replacement. So in such cases, you can go for arthroplasty. Then of course there's hemiarthroplasty, which I already mentioned last time, like for example, Austin Moore's processes or which I mentioned last time, right? Bipolar processes. Those are examples of hemiarthroplasty. So these are all the other treatment conditions which are used for IT fracture. Special considerations when SHS, that is a sliding hip screw, is used. Greater trochanteric displacement should be fixed to utilize tension band techniques. Basic cervical fractures treated with SHS or intramedullary nail may require a supplemental anti-rotation screw. So these are all special considerations which are used in surgical techniques. Then again, reverse obliquity fractures are best treated as subtrochanteric fractures, which I already mentioned earlier. Right. Ipsilateral fracture of the femoral shaft, that is on both sides, or on the same side but with the shaft of femur fracture also. It should be ruled out in case of high energy trauma. All those things we have mentioned earlier. What about postoperative care? Obviously, all the general things like a good pain control, then early mobilization. WBAT, that is weight bearing as tolerated. Weight bearing as tolerated ambulation. So according to what the patient tolerates, you can start the patient on weight bearing, gradual weight bearing. Then of course protein and caloric nutrition, osteoporotic therapy, proper balance and gait training. All these things need to be done in the postoperative period. What about complications of IT fracture as a whole? Loss of fixation, obviously. When the implant is put, there's always a chance of the implant failing or the screw backing out or something like that. So there's a loss of fixation. Non-union, although it is rare, it can happen. Then of course malnutrition, malrotation deformity. It can go for malunion. Then osteonecrosis. Again, not as common as neck of femur, but it can go for osteonecrosis. Then there's also Z effect. Again, it's related to the implant or whatever, the backing out of the screw or things related to that. So those are complications associated with the IT fracture. This shows just an X-ray showing the demonstration of Z effect, which I mentioned earlier, with one screw penetrating the hip joint and the other screw backing out. So that is what is known as Z effect. It looks like a Z or a Z, you can call it. So that is what is known as Z effect related to the implant. So these are all the complications that can be expected from a IT fracture. Then very briefly about, this is the major topic as far as trochanteric fractures are concerned, that is IT fracture. Then I already mentioned some fractures are purely confined only to the greater trochanter or only to the lesser trochanter. In such cases, for example, greater trochanteric fractures alone or specifically greater trochanteric fractures usually occur in elder patients as a result of eccentric muscle contraction, less commonly direct blow. Treatment is usually non-operative because only the greater trochanter is involved. You can treat it non-operatively. But in younger patients, you can consider operative management also. Usually, what's the treatment? If at all you need to operate, you can go for open reduction internal fixation with tension band wiring, or you can use a hook plate. These are the specific implants used for only purely greater trochanteric fractures. Alright, so tension band wiring or a hook plate. Tension band wiring is specifically used in certain fractures, like for example, one is this, that is greater trochanter. Then you can use for a patella fracture, sometimes for a medial malleolus fracture. So many things like that. So those are specific conditions where you use this particular technique, that is tension band wiring. So there you can see there, hook plate, that is what is known as hook plate, specifically used for greater trochanter fracture treatment. Lesser trochanter fractures, it is usually common in adolescents, typically secondary to forceful iliopsoas contracture. Treatment is usually identifying the pathological lesion. It's always associated with the lesion. Only if there is a lesion, you will usually get an isolated lesser trochanteric fracture. Otherwise, it's not very common. So obviously, you need to treat that lesion, whether it is metastatic or pathological lesion or whatever it is. You need to infective lesion or whatever it is. You need to treat that lesion specifically, right? So that is a specific treatment for lesser trochanteric fractures. Yeah, so that's it. That covers trochanteric fractures as a whole. Most important is, like I mentioned, intertrochanteric fracture. But apart from that, specifically, greater trochanter and lesser trochanteric fractures are also important to a certain extent. So this is usually asked as a long question, or sometimes even parts can be asked as short notes also. Okay, thank you very much.
Good.